Hey, ladies and gentlemen, boys and girls, my name is Mel Herbert, and it's time for another COVID-19 update, August 12th. It has been, I think, about 6 weeks since our last update. And the way we're timing these is when we think there's enough new information to be useful to you. Then we come online, and I think we've got some really useful information. A lot of the usual players are here. This map is just to tell you that there is a lot of this disease out there, and a lot of it here in the United States. So we're going to be fairly US focused today because we are the epicenter of this thing, and we are pretty much doing everything wrong. So we'll get into that a little bit later. But first, ladies and gentlemen, boys and girls, I want you to put your hands together for Jan Schonberger, who just became a full professor of emergency medicine. Jan, along with Swami, heads up the MRAP portion of the program. So congratulations, Jan. I hope you're embarrassed, but you shouldn't be because you're amazing. Amazing. So great work, Jan. We've got a PEDS conference coming up. Our first big virtual live conference. It's in 28 days. It's being run by Eileen Claudius and Britt Guest, who is downstairs because we have a physically distanced studio now. And Britt will be on in a second to give us some updates. She's running this show. So she's very stressed because 3,000 people have signed up. I don't know why she's worried about it. We've got an MRAP HD update coming to the site so that you can find all these videos and all these conferences and all this stuff way easier. That should be coming out within the next month or so. Just a paper that I saw just before this started. We're trying to work out why some people get really sick, why some don't. This is one interesting paper that suggests that perhaps if you've been infected with a related coronavirus in the last 2 to 5 years, this might afford some significant protection, and why we have people who aren't so sick and others that are. This might be good news for a vaccine to be effective, but the authors say, and I've taken this directly out of the paper, this is highly speculative. So you'll hear about this in the news, but just understand that they themselves looked at this data, but they're saying, like, we don't really know what exactly is going on here. I also suggest that you go to YouTube or somewhere, just do a Google search for this gentleman, Michael Mina. He's a PhD, MD from Harvard, and he has this out-of-the-box thinking about how we could fix this thing by using antigen testing. If you get a really cheap antigen test, even if the sensitivity overall is nowhere near as good as PCR testing, if you use antigen testing not to find cases but to find infective patients, and these tests are very good when you have lots of viral load early in the disease and while you're secreting it, this could really change the way we manage this thing. So you would do a test every single day, and if you're negative, you go to work, and if you're negative, you go to school, and if you're positive, you stay home. So go listen to this guy. I think he's got a really interesting idea here, which could potentially change the way we're dealing with this. And literally 15 minutes before we went live, we got this from a colleague of a patient who is sitting up, talking, yes, to Kipnick, but look at that waveform on the sat. It is perfect. And look at that number. It is 4. Do I believe that this person's sat is really 4? I don't think that's compatible with life. We've been hearing about 30%, 20%. When we get our experts later in the call, we can ask them, do they think that's real? But that waveform is pretty good. So Jenny Back-Ismay is in the chat room, so chat away, and she'll be collecting the best stuff, and we'll try and get to them as we go. Obviously, there will always be more questions than we can get to. And of course, we have to continue the silly game that we play, words that Stuart uses. Let's roll the video.
I can't believe you didn't know that.
You know, it's my favorite part of the show. Words that Stuart uses that you don't know. And this word, you know, is agglomeration. There's been a lot of words the last month or so, but agglomeration. We were talking about the situation here with COVID in the United States. Agglomeration, which means a bunch or a cluster. Words that Stuart uses. It's absolutely my favorite part of the show. Now let's do Corpendium Updates with Britt Guest. The chapter is continually being updated. We were updating like daily. Now I think Britt and Crystal are doing this about every week, but it has got a lot of new stuff, so I'm going to throw to Britt, who is downstairs, to give us the latest Corpendium chapter updates. Go, Britt.
All right. Am I going to be able to click through slides? Maybe? Oh, there we go. All right. So let's start with some Corpendium updates. We've been updating this chapter pretty regularly, like Mel just talked about. So there's a section on intubation and ventilation. And we know that early on in the pandemic, there was this push for early intubation, especially if patients were requiring about 6 liters of oxygen. Now, we know there's insufficient data to support that, and we know that early intubation is using a lot of valuable resources, as well as potentially harmful to patients. Now, when you do have a patient that you need to intubate, it's important that you practice lung protective ventilation. So this is addition to the textbook that we added, some key components to how to do that. Basically, low tidal volumes, usually about 6 cc's per kilogram based on their body weight. Permissive hypercapnia, that's, you're going to let the PCO2 ride a little bit higher than you might normally, of course, making sure that the arterial pH of the patient stays above 7.2. You want to avoid those high plateau pressures, so keeping pressure under 30, and then titrating PEEP using an ARDS-NET protocol, and then avoiding hyperoxia, meaning don't just set that FiO2 to 100% and walk away. You want to titrate and keep the oxygen saturation about 92 to 96%. We've talked about R0 quite a few times on the show, and this number has been evolving and changing throughout the pandemic. So early on, that R0, or if you become infected, how many people will you go on to infect, was about 4 to 6. Now we're seeing early, when we started doing really good infection control, we were wearing masks, we were practicing strict social and physical distancing, that number from mid-March to April actually dropped to about 1 to 4. Now restrictions are loosening, different states are practicing different restrictions, and we're expecting to see that R0 on the rise. We also have a couple terms that we've added to the book chapter. So super spreader, that's somebody who has a particularly high viral load, maybe doesn't have symptoms yet, and then goes into a crowded place, so like a beach or a restaurant, and really infects a disproportionate number of people. There's also speech supermitters, and those are people who just produce more droplets when they speak, and they also are infecting a higher number of people. Now, this paper came out, it was a study on about 2 million patients, and it was looking at the infection rate for frontline healthcare workers. And it showed that frontline healthcare workers had at least a 3-fold increased risk of becoming infected with COVID-19. There were different workplace issues that increased this risk, like not adequate PPE or reuse of PPE. And I think this paper just really points out that we continue to be at increased risk of this disease, and we really need to get our healthcare systems, both nationally and internationally, to continue to develop strategies to protect healthcare workers and provide appropriate PPE. In the section on the book chapter of severity of illness and mortality, we've known for a while that our ICU admission rates are higher in our older patient population, but there's been a lot more papers coming out indicating that quite a few young people actually need ICU level of care. And one paper showed that about 1 in 25 patients aged 20 to 44 actually required ICU admission. On the CDC website, there is a COVID-associated hospitalization surveillance network, or COVID-NET. You can find it on this link right here, that actually basically gathers data about COVID-19 positive patients from over 250 hospitals, over 14 states. And it will give information updated weekly on rates of hospitalization, as well as patient characteristics like age and comorbidities. Now here, we're just talking about testing with Mel. There's a lot of information coming out about PCR, antibody testing, a lot of conflicting information that can be kind of confusing to keep straight. So we broke it down in this table just to quickly compare the two. You can see there's pros and cons, different sensitivity indexes and lack thereof sometimes for these tests. And so this is a quick, easy access to just see the two tests compared to each other. Now, there's also a section on cardiology and kind of the extrapulmonary effects of COVID-19, and there's some interesting updates here. One was a study that came out of New York of about 756 COVID-positive patients, and what they found was, in these patients, if they had an initial EKG with a right bundle branch block, they actually saw that that was associated with an increased risk of morbidity and mortality. And it seems that the authors believe that this is probably indicating that that right bundle branch block is a sign of RV strain and could be an early indicator that this person is at risk of RV failure. All right, the last thing that I want to bring up is kind of the impact that this disease has had and this pandemic has had on society as a whole. There was a study that came out of the Cleveland Clinic Health System that actually showed that we're seeing an increased incidence in stress cardiomyopathy, sometimes also referred to as Takotsubo or broken heart syndrome. And what they found was that the incidence pre-pandemic was about 1%. And now during the pandemic, the incidence of stress cardiomyopathy looks to be like it's over 7%. The really interesting thing here is that in this study, the patients that developed stress cardiomyopathy actually tested negative for COVID. So these people did not have COVID-19. And so what the authors believe is that the increased incidence of stress cardiomyopathy is actually related to the socioeconomic and economic stressors of the pandemic and not actually the direct viral effect on the myocardium. So I think that's it for our updates, and stay tuned for more coming from the book chapter.
Great, thanks, Britt. So again, it's getting updated constantly with this information. It's actually worth sort of rereading, I think, every few weeks because so much more is being added. So our next section I'm very excited about because we've got Dr. Leana Wen. Now, you might know her because you may have seen her on CNN and MSNBC and stuff, but let me read her bio. It's pretty impressive. Dr. Leana Wen is an emergency physician and visiting professor of health policy and management at the George Washington Milken School of Public Health. She's also a distinguished fellow at the Fitzhugh Mullen Institute of Health Workforce Equity. She is an expert in public health preparedness and has been doing a lot of stuff on CNN, MSNBC, BBC, National Public Radio. She is actually trained in emergency medicine at Brigham and Women's Hospital, Mass General, and she has also been named by Time Magazine as one of the 100 most influential people in the country. So really a pleasure to get to speak to her just yesterday, and I asked her to give us an update from her point of view. So let's hear Dr. Wen. So Dr. Wen, thanks for coming. We want you to take off your ER doc hat, put on your public health hat, and help us understand some stuff that's going on. First of all, I was wondering if you could give us sort of from your public health perspective, where are we in the United States? How much virus is out there? What are we doing right? What are we doing wrong? Give us an overview from your point of view.
Yeah, well, unfortunately, I don't have good news in this regard because we are not in a good place. The US, we are 4% of the world's population, but we are somewhere between 20 to 25% of all the infections in the world and all the deaths in the world as well. And I think the worst part of all of this is that it didn't have to be this way. When we look at what should have happened, we had a chance back in February of actually containing this virus. If we had the testing, contact tracing, quarantining, isolation, we would have been able to test, find every case that is coming into the US and stop the infection in the way that South Korea did. South Korea had the very first case of COVID-19 diagnosed in their country that we did in the US. And look at where they are now with something like 300 deaths compared to our 160,000 deaths. Then we had another opportunity. We ended up going to this containment, going from containment to mitigation, and we locked down, supposedly with the idea of suppressing the level of virus low enough that we could then develop the testing, contact tracing high enough that we could rein in the infection once again. And unfortunately, we squandered that time as well. Half of the states didn't impose shelter-in-place orders. Many places did, and many students didn't go to school, and people lost their jobs. But we didn't use that time wisely. We reopened against a surge of cases of rising infections in many of our states, and we still don't have nearly the testing, contact tracing that we really need. And so, unfortunately, we are having a situation now where there are hotspots across many of our states. We have barely averted catastrophe in some of these Sunbelt states, only to see many other states now in the Midwest beginning to spike upwards. And I'm afraid that these waves of infections here in the US will continue unless we take much more dramatic action than we have.
What is the argument, the sort of the Swedish model, or the just let it go, like just let this thing go? What does a healthcare system look like if you let this virus with an R naught of around 4 and a low mortality rate overall, but still, significantly higher than flu? What does it look like in a healthcare system if you just say, let it go, let's get herd immunity?
Yeah, I think that we have already seen what that could look like. We've already seen New York getting hit so hard in the beginning. We've seen Texas, Florida, Arizona, and also not just in these big states that we're talking about, many smaller communities that have much less healthcare infrastructure have already gotten hit. But we haven't seen how bad it could get because thankfully we intervened. In the case of New York, the shelter-in-place orders we were able to avert the worst of what could have happened, with hospitals becoming so overwhelmed that we as ER docs and others would be put into the untenable and unthinkable position of deciding who could get that last ventilator. And that's what it could look like. And I think you also have to consider too, what is it for? As in this case, we don't know that we could actually get to herd immunity because we don't know how long immunity will last. So even if we could somehow get to that level of herd immunity where 60 to 80% of the population have it and therefore it protects everybody else in the community, we're talking about what, 300 million people, if it's 330 million people in America, we could be having 200 million, let's say, people who are infected before we get to that point of having herd immunity. And if you have a fatality rate of 1 in 100, I mean, we're talking 2 million people who would die as a result. And I just don't think that that's a reasonable approach for us to be taking when there are actually much better steps that we could take and that we've seen many Asian countries, European countries, we've seen Australia, New Zealand, they've been able to do this. We can too.
So I just wanted to sort of have you state that because I think some people that watch the show are not physicians and who don't get it. So this idea that just letting it go somehow will magically save the economy. You can't have an economy with a collapsed healthcare system. We've seen that in Central and South America. So I just wanted an expert to take us through that. So New Zealand hasn't had any community spread now for over 100 days. Just a remarkable job that they've done. How do we, if I make you in charge tomorrow, I make you president and you have all the powers that you need to run the public health of the United States, what would you do now to take us to where New Zealand is?
Yeah, I mean, there actually is something that we can do. I'm not sure, given the current politics and where we've gotten in this country, where public health has become so polarized and political, I'm not sure that we can literally achieve this. But, I'm an optimist. I think that we can if we just had our collective national will. Because when you look at countries like New Zealand, it's not as if they have something that we don't. It's not like they have a vaccine and we don't have access to it. And it's not like they've developed a secret treatment that nobody is able to get. They have the same things at their disposal. We know that this is a virus that's very contagious, that's easily transmitted from person to person, but it requires people in order to be infectious. And so what we attempted to do in the lockdown, what other countries have done, is to separate individuals. And so if everybody stays within their households, then all those people who are currently infected would only be able to spread it to their household. So we should be able to treat all those individuals who need treatment. But then technically, or essentially, it would stop at that point and not transmit further. So we could issue a lockdown, let's say, for 4 to 6 weeks here in the US. And we could, in theory, eliminate COVID-19 entirely, or at least suppress it to such a low level that the amount of testing, contact tracing that we have available right now would be sufficient. Now, this is what other countries have done. And by the way, they also reopen very carefully, which is important too, because I think here in the US, we've seen reopening as an on-off switch, that one day everything's shut down, and then another day, people who have understandably experienced quarantine fatigue are now going out there and doing all the things they were before. Actually, we should be seeing reopening as a dial, that you carefully dial back the restrictions, and then you carefully dial it up again once you see that if cases are going in the wrong direction. So we can actually do this, but it's a matter of political will and really emphasizing that this is a public health problem that should be driven through a public health response, that politics have no role in it.
So let's talk about reopening then. There's lots of states that are talking about reopening schools, both high schools, middle schools, universities. What are the public health requirements to do that safely? Politics aside, from a science point of view, what are the data points you need to have in order to do that?
Yeah, the single most important determinant of whether schools are able to reopen safely is the level of spread in that community. You can imagine, let's just do the math. If you have a community where the rate of infection is 1 in 100, and you have a school of 1,000 people, that means on day one, you could be reopening schools and there'll be 10 people who have the infection but don't know that they have it and are actively spreading it to others. And in fact, we've seen already that in schools that have reopened against this backdrop of surging cases in Georgia, in Texas, and other places, that they've had to shut down really rapidly because these few cases become outbreaks very quickly, especially when we don't have the surveillance testing that we need to rein in the infection. So we absolutely need to have the level of infection at a low enough place. Now, there are parts of the country where they do have a low enough level of virus, and in these places, they can theoretically safely reopen as long as they also increase their public health infrastructure or improve their infrastructure in other ways. So, for example, de-densifying classrooms, making sure that there's 6-foot distance between desks, and that may include staggering opening times. That may include also having different bus routes. That may include hiring different teachers and allowing some teachers and some students to do virtual learning or hybrid learning. That also includes having cleaning procedures in place and having PPE available, because why should PPE only be available to those of us who are healthcare providers? It should also be available to teachers and to other staff in these schools too. So to do all of this is going to be expensive. It'll take new resources, it'll take new staff. And I hope that that's what our politicians can be focused on. Instead of these arguments justifying reopening where they shouldn't be reopened, why don't we instead focus our energy on how do we make schools safer? How do we invest the resources so that it protects not only the students, but also really importantly, the teachers, the staff, and their family members too?
So I don't know if there is an answer to this. The arguments against doing this the right way are social, political, but also financial. Is there modeling out there that has looked at this for prior outbreaks and that have said, if you do this right, if you do this aggressively, if you shut things down, you'll be able to reopen faster, and economically it is better or worse? Is there any sort of modeling about which is the best way? Because we look like we're in a place where we are going to open and then close, open and then close, and this could go on for months and months and months. In South Korea and New Zealand, they're open.
Yeah, I mean, I think we are seeing this kind of modeling, if you will, happen in real time. That the countries that were able to reopen because they closed down efficiently the first time, that yes, there was a lot of short-term pain, but that medium term to, I would assume also longer term as well, that their economies rebounded a lot faster. I mean, we just can't have a functioning economy, Mel, when people are too scared to go to the grocery store, when consumer confidence is low because they're not going to want to go retail shopping. I mean, who wants to go shopping when they're looking outside and they know that patients with heart attacks and strokes can't even get into the hospital? I mean, that just is not going to happen. And so I think part of what's gone wrong in this country is that we've pitted the public health as an entity against the economy. And somehow people have been putting this as, well, do you believe in public health or do you believe in the economy? That's not the right question at all. In fact, public health is the roadmap to reopening. Public health is the roadmap to reopening schools. And I hope that we can also think about our values in all of this too. You asked earlier about reopening schools, and there actually is a path to reopening schools safely, and that's suppressing the level of infection. And so maybe we should be thinking about, do we want our bars to be open or do we want schools to reopen? If schools are truly so essential, as I believe that they are as a parent and as someone who used to run school health in Baltimore, I absolutely believe that kids belong in school. But if that's the case, then we need to decide about our trade-offs. We should be looking at coronavirus in the same way that we look at a city's budget. A city can't just have endless budget. you have to decide what are your priorities. Do you invest in housing, policing, education, health, etc.? And in this case, if our priority is schools and children, then we should be also deciding which are the businesses that need to be kept closed in the meantime, while we support small businesses and employees and keep people whole. But we also have to make these difficult trade-offs because we cannot have our cake and eat it too.
Lastly, I wanted to ask you, because I know nothing really more than any general doc about vaccines and how they're made and how quickly they can be dispersed and how effective they may or may not be. Can you give us any more expertise on what you think is likely to happen with a vaccine, whether this is the magic thing or whether it is a combination of vaccine and still significant public health interventions?
Yeah, it is going to be both. I hold out hope for a vaccine. I think that there are such extraordinary efforts with so many candidates now in the pipeline that will have multiple shots on goal. And I think there has been extraordinary investment also in the vaccine process. And so there is a lot of funding, for example, on producing the vaccine even before all the trials, all the phase 3 trials have gone through, so that production can be ramped up quickly if one of these candidates does turn out to be effective. So I'm optimistic that we will get a vaccine. But first, it may take well until the end of the year, early next year, for phase 3 trials to be complete. It's also going to take much more time for us to ramp up production and distribution, because ultimately it's not the vaccine that saves a life, it's the vaccination. We have to get the vaccine into people. Also, this vaccine is almost certainly not going to be anywhere close to 100% effective. I think we'll be happy if it's 60 to 70% effective, which is more effective than the flu vaccine. And it may be something that people need to get multiple doses of. Maybe they need to get a booster shot. Maybe they need to get this every year regularly, as we do it with the flu vaccine. So all this is to say, this is not going to be the silver bullet. And we still are going to have to be really vigilant when it comes to these other public health practices. And I also think that we cannot wait until we have a vaccine when all these preventable infections and deaths are occurring. We should not be saying when and if we get a vaccine, everything's going to be fine, because there are things that we can do right now. And we are talking about not only our economy, but also fellow American lives. I mean, in the time that you and I have been speaking already, we're talking about 5-6 people who would have died from coronavirus here in the US.
That's all I've got. Do you have anything that you want to talk about that I haven't touched on?
I mean, I think only to appreciate the incredible work that frontline providers have been doing. ER docs, nurses, nurse practitioners, PAs, techs, respiratory therapists, EMTs, paramedics. I mean, I'm forgetting so many others, but I think it's just been extraordinary to see the sacrifices that they have made and are continuing to make, and the extraordinary work that they're all doing in this extremely challenging and ever-changing, uncertain time.
Yeah, and I think we all would second that. And I'd also like to thank you for the work that you've been doing. You're on television a lot. You're trying to get the message through. And I know that all people like you, Dr. Fauci, have been getting death threats and just ridiculous things for speaking the truth. So thank you for the work that you've been doing. It's extraordinarily important. And thanks for spending the time to come and speak to us. We're really proud of you as an ER doc and as a public health doc. So thanks for everything you're doing.
Thank you very much.
So thanks again to Dr. Wen. We are so proud of her, and actually Swami and Stuart remember her from way back when she was just applying to residency. So a lot of useful information there, but I'm sure that some of you noted that things have changed already. We recorded that 24 hours ago, and New Zealand had 4 cases. And so they are locking down into phase 3 for 3 days while they do some more contact tracing and put everybody away for a little bit. Just understand what that means. That's 4 cases in over 3 months. The United States is having 50 cases every 1 minute. Now let's talk about therapeutics, and we're going to show a little video here of Sean and Stuart, and then they're going to take some questions.
All right, thank you so much. Let's get going again. It's been about a month and a bit, hasn't it, Sean?
It has, but there's stuff to talk about. There's always stuff to talk about. It.
Yeah. But I mean, let's go ahead and get into it. We're going to talk about drugs first, and then we're going to go into some of the antibody stuff, which is exciting, and then finally end on vaccines, where I think we're ultimately headed here. Chloroquine, hydroxychloroquine, only more negative. Really, nothing pointing towards using this, and no new data on a whole bunch of the agents we've talked about. And you had kind of a a theory about why we haven't seen any more publications yet, right?
Well, I think it's twofold. I think there's a little bit of a lull before the storm. So I think in the next couple of months, we're going to see a mountain of data coming. But I also think a lot of editors of journals are a little gun shy after those very public recalls of peer-reviewed data. So I think that people are just being a little bit more scrutinizing of COVID data.
Yeah. So it gives us less to talk about, but the really big news, I think, and very practical, is with remdesivir and steroids, both of which have very recent NIH guidelines and recs that we're going to go over. So let's get into that. The remdesivir, this is the treatment guideline. I'll let you talk about that, but basically we have to prioritize who we give it to, right?
That's it. So really the questions with remdesivir are, number one, who do I give it to? Right? I think that's everybody's question. And then number two is, can I get it? And there's an availability issue. Now, if you remember how this drug works, this drug inhibits the viral replication. So it makes sense to give it earlier in disease. So the recommendation is to give it to patients that are requiring supplemental oxygen, not high flow and not mechanical ventilation. But if they're not on any oxygen therapy, they shouldn't get it either. So there's kind of a narrow patient population that probably should get that. And that's probably, as you mentioned, a function of the availability. As it becomes more available, maybe that'll be expanded a little bit.
Yeah, I mean, it's really expensive. And so that's with remdesivir. And the steroids, big thing in the guidelines. We were just using it initially, I think, in ARDS. And this is really expanded. Ventilated patients, patients requiring supplemental oxygen.
So this is based a lot on that recovery trial that we discussed last time. But if you look at it, it's just not mechanically ventilated patients with ARDS, as you mentioned. It's anybody who's mechanically ventilated, but also anybody who's getting supplemental oxygen. So this is really expanded quite a bit. And then their recommendations, and I agree with this entirely, is if you don't have Dex, Dex is the preferred. But if you don't dexamethasone, you can use really any corticosteroid that you have because of the apparent benefit in those subset of patients, the sicker ones.
In this paper that we decided to show, it's not like it's a great paper or anything, but there's something really fascinating. I mean, there's lots of positive data for steroids, like the recovery trial. This is a small study. It's not particularly fantastic in the methods, but what it does show is that there's sort of two subsets of patients, right, depending on their inflammation.
That's right. And so this is a study, it's out of Montefiore. So if you're not familiar with that, that's in the Bronx, a big hospital system up there in the Bronx. And this was in kind of the peak when they were seeing a lot of stuff, March into April. And what they did is they just noticed a lot of clinicians were prescribing corticosteroids. So this wasn't a proper trial in the sense that people were randomized. It really is a retrospective observational study. But what they did is they had about 1,800 patients over this time period, of which 140, so small numbers, got corticosteroids. But what was interesting, when they looked back at their data, who did the best with corticosteroids were patients who had very high CRPs and who got early steroids, which makes sense. If you're thinking about, hey, these are the people who have that cytokine storm going on, it supports some of the data that we already know. So they had not only a mechanical ventilation decrease, but a mortality benefit. Conversely, people who had a low CRP but got corticosteroids, they actually had an increased mortality compared to controls and increased risk of mechanical ventilation. So again, there's a little bit of nuance with giving corticosteroids.
This is even more interesting to me. I mean, presumably steroids could really backfire if you're giving them early on in a patient who's immunocompromised, and there's those concerns. And so naturally we wonder, hey, why not just inhale them? And so there's a little bit of information on that, but no evidence of benefit or harm is what they're saying.
Yeah, so, this one I included because this is a little bit older. This is from May, but I've had a lot of people asking me, shoot me emails, or just, if I run into them saying, hey, what do you think about systemic steroids? What do you think about inhaled steroids? So what's interesting, and this is from the European Respiratory Journal, and it's from the UK. But what was interesting, this is a systematic review that they did. And if you look at it, and this is quite interesting, people with COPD and asthma don't seem, at least from the epidemiologic data we have thus far, to get this disease more often than the general population. So that raises a question. Maybe these inhaled corticosteroids or the therapies they're on might be protective, or maybe these people just know, hey, I'm at higher risk, so I'm hiding out indoors more so than other people. Now, to be clear though, if you have COPD and you get severely ill, your mortality is higher than the general population.
It's much higher, right? So it's you don't want to get it. But I think the important question is that, if you're a COPD patient, you shouldn't be stopping your therapy.
That's right.
Right.
That's my take home. So what they did is a systematic review, and they looked not only COVID, but they also looked at SARS and MERS data. So they identified 59 publications, lots of limitations, too much for us to go into. But what they showed is that there was no benefit, but there's no adverse event. So exactly what you said, if you had a patient, or if I had a patient who's a COPD patient, who's well controlled on inhaled corticosteroid, I would continue it. Because my concern would be if I de-seed it and then that person goes on and gets COVID, if they get severely ill, they're going to have a worse outcome. That being said, patients with COVID should not be getting inhaled corticosteroids.
Now we're getting into a more exciting territory as far as I'm concerned. We have, this one's a preprint. We're really optimistic about this, but we really don't have enough. And these are very heterogeneous studies, right? You can't compare them and make good conclusions.
I agree. And, you know that I am, and I think you are very bullish on convalescent plasma, but we have to be balanced, right? So this is from medRxiv. It is not peer reviewed. It's pre-published data. But what they did is they looked at pretty much the available data that's out there. So they looked at, there's 3 RCTs, there were some case control studies, and there's some case series. And what they had was 804 identified patient outcomes. And what they showed is there's an overall mortality benefit of between 12 and 13% in the patients who got convalescent plasma compared to patients that did not. Now, there's loads of limitations, right? There's not standardized dosages of convalescent plasma. There's not standardized therapies, right? They're getting anything. These are different countries at different times, different resources. And of course, there's probably some publication bias in there because if there was a lot of negative stuff. So we have to be a little bit careful, but this is what we have to date, showing that convalescent plasma may have a mortality benefit.
Right. We just don't know the who and when and the timing. You can't say that yet, right?
Absolutely. Absolutely. We have to be really careful how we interpret this.
Okay. I feel like we're building up to a climax here because there's been a lot of buzz about monoclonal antibodies and a lot of, positive energy, shall we say. And because this is the concept here, of course, is that this could be the bridge, right? This could be the bridge that we get to people that are exposed or that are very early on or they're at risk even, and give them, some degree of.
Yeah, well, this makes sense. I mean, if you think about monoclonal antibodies, if you think about vaccination, if you think about convalescent plasma, they make sense, at least to me, because what you're doing is you're providing passive immunity. So these are actually pretty cool. The way that they are making these products specifically for COVID is they're getting antibodies from recovered patients. They're isolating them, and then they're making monoclonal antibodies. Now, some of these products are one specific one. Some have a number of different monoclonal antibodies, but the goal is to buy some time, and buy some time in many different ways. So if you look at who's at risk, well, you and me, right? If we're on the front lines, and every other person who's listening here, frontline workers of any stripe, right? If you have the grocery worker or whoever it is, nursing home patients. And also we worry about them because the vaccines, very often they don't respond well to vaccinations, even if we have a great one.
See, this is the thing. And so, I'm thinking especially of patients that are elderly that, they might not mount a response. And we see the same thing with tetanus, for example, and we might need to cover them with immune globulin or with monoclonal antibodies in the interim, right? It's a bridge almost.
It is. So there is the real big ones from Eli Lilly that's coming out. And there's this it's called the Active 3 trial. It's a phase 3 trial that's starting up right now. But this is interesting because these studies are quicker. They're easier to do. So the data will come, and I think they'll come to market quicker than the vaccines. Ideally, they'll both come out at the same time. But remember, the vaccines are going to take a long time to ramp up to make because there's storage issues and less of an issue with monoclonal antibodies. But remember, these are only going to last for about 3 months or so, where ideally a good vaccine will be a year or maybe more. You might have to get this vaccine each year, but the monoclonal antibodies you're probably going to have to get several times a year, if not more.
Now, without further ado, I want to get into these vaccines. I want to tell people what's going on. And what I did here, Sean, is I made up a slide just with the 3 phase 3 trials, the ones that for sure we know are in or going into phase 3. And I put a line down the middle because there are really two major types here. There's the messenger RNA, and then there's the adenovirus, the inactivated or non-infectious adenovirus vector, right? Tell us about what's going on.
So these are really, and let me just say, I mean, this is when, you think about people sharing data. So Chinese scientists made the genomic code for coronavirus, COVID-19, available very early. And that's how everybody can make these so quick. So you're not growing the actual coronavirus, you have the genetic code. And specifically, these are all pretty much targeting the spike protein, because the spike protein is how it gets into the cell, and it seems to be the most immunogenic. But these are really interesting. So if people have heard, well, this is kind of a whole new ball game, it is. With these messenger RNA, is kind of the new way to make viruses, and we'll get that in a second. And then the adenovirus, it's just a carrier. So it's
that's old school. That's old school. That's like the old smallpox that's carried in on another viral vector. Yeah.
That's it. So what they're really interesting, and we won't get into the kind of the real meat and potatoes about how these are made, because they're both messenger RNA, but they're different. But what they do is they have messenger RNA that gets presented to T cells in the body, and then actually create the spike protein. Well, the messenger RNA goes into the cell, creates it, and then it gets presented. So the thought is these are going to be very immunogenic, which is a good thing, because you actually have the spike protein being created in vivo. And some of these might be better for those elderly patients, because again, they might not have as a good response with sort of the more traditional. Now, we don't know, that's just theoretical, but that's where you look at that. But there are some issues compared to that, because the problem with messenger RNA is that they're pretty unstable.
And you have to like freeze it to -80.
-80.
Yeah. So maybe not a great idea for a developing country that's gonna, it's hard to transport.
It is, right? Because if you think about you get your Tdap, right? If you go for whatever, they take it out of the refrigerator, right? When you're there, that's -5 degrees Celsius. This is -80. So it'll break down really, really quickly. So there might be, particularly in places that are a little bit resource poor, third world countries, this may not be ideal. So what we want and what I want, and there's more than these are kind of the three kind of lead ones, and that we're thinking about, but there's other technologies that are coming. But what we want, or what I want, is for all these to be successful and all to come out at the same time, because you might target some of these for specific patients. Like the messenger RNA might be better for the elderly patient. Young, healthy people, it might be the Oxford vaccine. I mean, this is just me thinking out loud, but that's kind of where we're at with this. But it is a very exciting time. And ideally, probably early next year, we're probably going to have one or more of these coming to market.
Yeah, I think we're all going to learn a ton. I mean, I've already learned a lot, but we're going to learn a ton about vaccines and the differences between them. And we need this patchwork because of what you're saying, because we're going to have to tailor the therapy towards availability, storage, expense, all these issues, these practical issues that will make it more appropriate for some regions and not others, right? So it's such a good thing that we have so many down on the pipeline.
That's true.
So lastly, Sean, every time we promise to introduce a new drug or talk about something we haven't talked about before, and we do have something this month. And the only way I could describe this new therapy is kind of a potentially oral version of Remdesivir that could give us a head start in some of the high-risk patients. Might be cheaper too, right? Yeah,
I think that's a perfect thing, because this works the same way that Remdesivir does. This is Favapurivir. So it's an RNA-dependent RNA polymerase inhibitor, and ideally decreases viral replication. It's been around in Japan for a long time. It's used for resistant influenza. But the good thing, unlike Remdesivir, is that it's oral. And there's phase 3 trials going on, and I think people are going to start hearing about it. The manufacturer just came out with some preliminary phase 3 trial data that looks promising. So we thought it was a good one just to kind of bring up this month, because people might start hearing about it.
That brings us to the end. Basically, we're really hopeful. We're really hopeful that we're going to have these so-called bridges, that the drug bridges, even better, the antibody bridges, and then hopefully all these great vaccines that will make life hopefully get back to normal soon. So,
I'm hoping too.
Thank you so much, Sean.
All right. Great seeing you.
So, Stuart.
Okay. Yeah. So, Sean, we have a question from Ian Light about hyperimmune globulin. And so I actually remember when I was younger having to come into the doctor to get hyperimmuneglobulin when they thought someone in my family had hepatitis. It was sort of giving us that short-term passive immunity. It's essentially, isn't it a concentrated form of convalescent plasma, isn't it? I mean, is there anything different to know about that? It's a good question.
It's a great question, and you're exactly right. I mean, it's in the name, right? Hyperimmuneglobulin, and so you can think almost of, say, thousands of people. And it can be given intramuscular very often. Probably when you were a kid, you probably got it intramuscular. So it's a concentrated form, and it can be commercially manufactured. So there's a lot of pluses to it, but it's still early days. I think if the convalescent plasma seems like it's really working, I think you'll see hyperimmuneglobulin probably get ramped up quite a bit.
All right, and so now we're going to punt it over to Swami, and you've got also some questions you're going to take.
Yeah, we had some stuff lined up for me to talk to Sarah about, but we did have some questions we wanted to get into. There were a couple of questions surrounding the use of non-invasive ventilation, whether it be high flow or CPAP. There's still some people concerned about the spread from those, so the spread to other healthcare workers. So I know we've discussed this many times in the past, but I think it is an important topic to get back into. So Sarah, what is the role for using high flow nasal cannula, CPAP for these patients? Are you guys doing it where you are? Do you think we should be embracing that therapy in patients before we get to intubation?
Absolutely. I think that increasingly people are becoming more and more comfortable. I mean, I remember the first time I did BiPAP at one of the hospitals I worked with, people were so uncomfortable with it that I had to be like, all right, guys, I'm going to go in myself with PAPR on and put the patient on there by myself in the room so that nobody else has to feel exposed. Now it's becoming so much more of a routine thing because we're routinely starting all these patients on high flow nasal cannula pretty much by the time they're in the ICU and even thinking about needing intubation. BiPAP, CPAP, it's a little bit less clear in terms of, are people doing it? Yes, people are doing it. In terms of whether it helps, personally, I feel like if they're failing high flow nasal cannula, I will try it out. If it seems like it's helping the patient's work of breathing, fabulous. If not, didn't work, I'll go back to high flow or intubate as needed.
All right, so I think the thing that you said in there that's really important is the level of PPE. This is clearly going to be aerosolizing. Yes, you can reduce that by adding filters on the exhalation side, on the inhalation side. That'll definitely help to reduce that. Mm-hmm. But we were doing the same thing. We're using CPAP because we're running low on vents. We didn't have anything else to offer. And we had not that long ago, we talked about how to put together a CPAP device when you run out of CPAP machines, which also will happen. And we can drop those back in somewhere for people to look at them. You can do this safely, but you probably have to have an N95 on. You should have a face shield on because it's going to aerosolize. So protect yourself as well. But keeping people off of vents is always a good thing. Another question that we had, Sarah, was about one of the blood tests that sometimes people are seeing, which is BNP, the brain natriuretic peptide that we all love. I don't know if you guys are getting these routinely in patients with COVID. Are you seeing elevations when you do get them? Or maybe the better question is, in what situation are they useful to get?
So I'm not getting them routinely. Some people have been. So I have all these COVID patients with BNPs. I have no idea what they mean because there's all kinds of reasons, the usual reasons that they could have a high BNP. Did somebody give them 15 liters of fluid? Maybe so. BNP is elevated, okay? Are they having right heart strain? Do they have a PE? So I'm not routinely getting them in these patients because I don't know what to do with that number once I get it, is the problem.
Right. Another lab test that we are getting routinely, I know you're getting it routinely also, and it kind of bridges us into talking a little bit about thromboembolic disease and what we should be doing for prophylaxis, is the D-dimer. I think that's probably a routine part of many of the panels for COVID. I'm assuming that you guys are getting these pretty frequently. So let's talk a little bit about venous thromboembolism management. So I have a patient, I'm admitting them. Which patients should be getting the prophylactic dose of anticoagulation? Who should be getting full dose? Do we know the answer to that? Or let's say that we don't know the answer. What are you doing for your patients?
So in terms of the ones who are critically ill, I mean, I think any COVID patient who gets admitted should be getting prophylaxis, period. In terms of the ones who are critically ill, it's not just sort of prophylaxis versus therapeutic anymore. Now we're talking about high dose prophylaxis. So what do we mean by that? So to me, and for a lot of people now, we're doing high dose prophylaxis for all critically ill patients, period. And what that means is generally Lovenox, 0.5 mg per kg every 12 hours. If they have renal failure, their creatinine clearance is terrible, you may need to reduce that dose or change it to heparin. If they have HIT, you can do fundaparinox, but really what most people are doing for as many patients as they can who don't have a hard contraindication to anticoagulation is high dose prophylaxis. Lovenox 0.5 mg per kg Q12. In terms of what do you do when switching to therapeutic anticoagulation? How do you decide that? Because, I think previously there was a pretty high threshold for therapeutically anticoagulating critically ill patients. And that's kind of gone out the window with COVID patients. And this is one of the times that I never thought I'd say this, but a D-dimer is actually useful. Who knew that would ever happen? But the D-dimer may actually be useful. So if I have a patient and either their D-dimer is going up really fast or it's really high, like greater than 5,000, depending on your units, greater than like 5-6 times upper limit of normal, that actually for me, and increasingly for a lot of people in the critical care universe, has become a trigger for just full-on therapeutic anticoagulation. Again, Lovenox is my preferred drug here if I can use it. But if there's anything else, like any hint of any kind of thrombosis, I mean, obviously if they have a DVT, but keep in mind here, don't go back to our thoughts about, okay, DVT prophylaxis as usual. Well, if it's superficial and in the arm, no. In COVID patients, any DVT anywhere, I start therapeutic anticoagulation. If they're clotting off their lines, you're like, I just put in the central line, all the ports are now clotted. If they're clotting off their CRT circuits, and some people are even saying, if they're just abruptly or rapidly having hemodynamic or pulmonary decompensation and you don't really know why, some people will do it for that reason. So case by case basis, but the bottom line is high dose prophylaxis for all critically ill patients and a lower threshold than we're used to for therapeutic anticoagulation in these patients.
All right, let's summarize one more time. If you're admitting them to the hospital, they should get prophylactic dose of anticoagulation, which we should have been doing already. We're just helping out our inpatient team, maybe by starting it ourselves. If they're critically ill, you're going to usually be recommending full dose anticoagulation. There is that gray zone of patients. So there's that patient who they're sick enough to come into the hospital. They're maybe not sick enough for the unit, and the criteria for going to the unit changes quite rapidly when you get really ingrained in this pandemic. But their D-dimer is that 5, 6, 7 times the upper limit of normal. And we were putting those patients on full dose as well, as long as they didn't have contraindications. I think we do, and I know that you're echoing this too in your statements, we have to make sure that they don't have hard contraindications. So, they had spine surgery yesterday, they had a recent intracranial hemorrhage. Maybe we're gonna have to be a little more wary about those patients, get a little more guidance, but otherwise, especially when you're really surging and your ICUs are overwhelmed, this is gonna fall on us to start that, right, in the emergency department. One of the questions we always get, Sarah, is should we be sending patients home with anticoagulation? And I know that you're not doing as much emergency medicine, you're doing more of the ICU stuff. And if you're sending patients out of the ICU, you're very likely going to be continuing anticoagulation on those patients. From my perspective, I rarely am discharging a patient who's sick enough to need anticoagulation. But there are some exceptions to that. So we've had a couple of patients who came in who had COVID. They clearly had COVID, but they weren't hypoxic. They weren't tachypnic. They passed a walk test, and we wanted to send them home, but they had a history of venous thromboembolism in the past. And we felt very comfortable restarting them on anticoagulation in conjunction with their primary doctors. So those are cases where I think it's probably good to start on anticoagulation. But for most of the patients, if they're sick enough to need anticoagulation, they're probably sick enough to stay in the hospital. And again, discharging from the ICU is a little bit different.
Yeah, totally. And I think that there are a number of protocols that try and lay out specific criteria. But again, most important thing, hard contraindications to anticoagulation have not changed. Soft indications have. Critically ill, high dose prophylaxis is sort of a level of anticoagulation we're not used to doing. Therapeutic anticoagulation really have a low threshold for starting that.
And the best that we have on this topic are some retrospective studies. We don't really have any good randomized controlled trials. They may come down the line, they may not. This is the best we have. Let's branch into something that we have even less data on that you wanted to talk about, which is pulmonary vasodilators. We talked a little bit about this offline, and you're gonna have to walk us through this a little bit, maybe going back to some of the pathophysiology of COVID, of why a pulmonary vasodilator might be useful for these patients. So let's start basic. What's the pathophysiology that leads you in this direction?
Yeah, so it's interesting because, with anticoagulation, even though we don't have the data, there's still pretty robust agreement in the critical care universe about what the right thing to do is at the moment. In terms of the pathophysiology and the use of inhaled pulmonary vasodilators, not so much. So what are they and why do we care about them? And you really do have to start with this COVID pathophysiology question. And I think increasingly, people are shifting from thinking of COVID as a lung disease to thinking of it as a vascular disease. And there's this increasing population of people in the critical care world who believe that failure of ventilation perfusion matching is central to the COVID pulmonary pathophysiology. So we should start with remember way back in med school when you were listening to a lecture and somebody talked about VQ matching and you fell asleep. Turned out that was actually kind of important. The bottom line is there's 17 ways to explain this in a complicated way, but it's not that complicated. If you are the lungs, there are different parts of the lungs that have better oxygen and worse oxygen. You want to send the blood to the parts with the better oxygen. That's it. That's the idea. So if that's the idea, if you're the lungs, you're trying to send the blood to the good areas of the lungs, well, what's going on during COVID? Because, it's not new, the idea that VQ mismatch contributes to lung disease. That's not new, or it's not unique to COVID, certainly. We know this about ARDS and many other lung diseases. But at the same time, the idea that VQ matching problems, ventilation perfusion matching problems, may be a primary driver of COVID physiology has become really attractive to people because it might help explain some of the things we're seeing clinically. So for example, the happy hypoxic thing, where we're just having this disconnect where the patient is profoundly hypoxic, but they're kind of like, I'm okay, I'm breathing okay, because their lung mechanics are relatively normal. So they're not really experiencing that shortness of breath. In addition, the observation that for a lot of COVID patients, their oxygenation improves with proning. Now, this was confusing for a while, but if we remember that proning does two things. Yes, it helps recruit alveoli, which is probably a lot of the reason it helps in ARDS, but there's a second thing that proning does. Proning redistributes pulmonary blood flow in a way that improves your VQ matching. And so might that be the reason why it's helping COVID patients, or especially the early ones? And so what's become really interesting is that now we're having this pathophysiologic evidence suggesting that COVID may be causing the pulmonary vasculature to do exactly the opposite of what it's supposed to be doing. So, you know how COVID lungs on CT scan, on chest x-ray, they're patchy, right? There's some areas of the lungs that look great, others that look awful. You have good patches, bad patches. The good patches get lots of oxygen, bad patches don't. Okay, what the pulmonary vasculature is supposed to do in that situation is send the blood to the good areas, prevent it from going to the bad areas. That's what's supposed to happen when VQ matching is working. But what's become really interesting is that in COVID, what seems to be happening, or at least there's some evidence that what seems to be happening, is that instead, exactly the opposite is happening. Instead, the pulmonary vasculature is vasodilating in the bad areas of the lungs. It's losing its ability to vasoconstrict in response to hypoxia. It's vasoplegic in the bad areas. And then to make matters worse, there may actually also be vasoconstriction in the good areas. So increasingly, VQ matching is taking on a yet unclear but more prominent role in the pathophysiology. Okay. So if that's the pathophysiology, if that's what we're thinking, well, we have a VQ matching problem. Why don't we give something that improves VQ matching? And the thing that improves VQ matching are inhaled pulmonary vasodilators. So,
Sarah, I'm sorry. Let me just take a pause.
Please.
Let me just sum this up a little bit. So you have a state where they are pulmonary vasodilated. Everything's vasodilated, but some of
in the bad areas, it's vasodilated.
Right, but the bad areas, but what we want to do is actually vasodilate the good areas and then try and get more blood flow to them. So these are areas that when the patient is inhaling, there's gas going into that area. So if we give them something inhaled, it can get into those areas preferentially. That's the theory that's behind all of this.
Yep, that's the one, is that you want to vasodilate the good areas of the lungs. You want to send blood to the good areas. Now, the best way to do that is to take a medication that dilates the pulmonary vasculature and only send it to the good areas of the lungs. Now, if you give it IV, if you give it systemically, that doesn't really work, right? That actually makes your VQ matching worse because you vasodilate everywhere, the good and the bad areas. But if you give it inhaled, by definition, it has the highest concentrations in the good areas of the lungs, right? That's where you're getting the best ventilation. So that's why people are thinking maybe some of these inhaled pulmonary vasodilators may help in COVID. So
and
that
Sarah, what
sounds
are our
great.
options for inhaled pulmonary vasodilators? What can we use? So we're not going to use, again, we talked about this before, but we're not going to use things like ibuprostanol, right? Because that's IV. What can we use oral, or I'm sorry, inhaled?
Yeah, so most of the forms have an IV form and an inhaled form. And the usual ones that I use in the ICU are inhaled nitric oxide, and then Flolan and Verlitri, which are just brand names for epoprostanoids that you can inhale. Those three medications, especially nitric oxide, are very expensive, and you can't always get them in the emergency department. They can be a little finicky to administer. You need specialized equipment to administer them because they're continuous inhalational things. But in the ED, there turns out other stuff we can use that we're very familiar with. So for example, nitroglycerin. We all know nitroglycerin comes in that nice little glass bottle. Turns out that nitroglycerin actually physiologically, once it's in the body, acts like nitric oxide. It gets converted into nitric oxide, and so you can actually inhale it. And there have been some studies of this, and it's a little tricky to do just because it's a really big volume, but it absolutely can be done. So that's one thing that people are doing. Inhaled milrinone is another one. So yes, we're all familiar with you can give IV milrinone, but it turns out you can take the same stuff and give it inhaled. So these aren't just drugs that we'll only ever have access to in the ICU. These are things that I do in the emergency department and we feasibly can do. But the real question is not so much the feasibility. The real question is this just another item on that long list of things that seem like a great idea physiologically in theory, but don't actually work? Maybe. We don't have a lot of data here. You know, in ARDS, they've tried this, and this data is all over the place. It seems to improve physiologic parameters, but not like patient outcomes. But the literature is super complicated, and I honestly don't know what it means in ARDS. There is one study of 14 whole patients in SARS where it improved hypoxia and ventilator days in 14 patients, okay. And we have no published data in COVID. But stay tuned, because there are two studies now ongoing. And they're both, I hope, going to be very interesting at the very least. There is a phase 2 study of using nitric oxide in sick intubated patients. So you just like put it through the NG tube or the ET tube, you nebulize it, you give it continuously. Can this prevent progression of pulmonary disease? Can this prevent hypoxia in the sick intubated ones? There's also an interesting phase 3 study actually looking at the less sick patients to see if it can prevent them from needing intubation. Because it turns out you can give this stuff through high flow nasal cannula, through CPAP, through, even if you need to, a regular nebulization mask. So there's these two studies ongoing. Keep an eye out for them, because they hopefully will be very interesting. And if this works, this is something that we could feasibly roll out on a larger scale if it works either in the sick ones or the less sick ones.
Sorry, let's just clarify one thing with the inhaled nitroglycerin. Obviously, we use nitroglycerin a lot. We're very comfortable with it. It's pulmonary, it's a vasodilator, excuse me. Now, in the inhaled form, how is that working exactly that the nitroglycerin is causing pulmonary vasodilation?
So it works the exact same way as it does in the IV form. It's the exact same stuff. It works the exact same way. However, the special thing about giving it in the inhaled form is, one, it doesn't tend to drop systemic blood pressures. Because, you know, the first time I proposed this, people were like, oh, but these patients are septic and hypotensive, and nitroglycerin, it does not tend to drop your systemic blood pressure because you just don't get enough systemic absorption. But more importantly, when you give it by the inhaled route, the mechanism of action is exactly the same. It doesn't change, but where it goes does change. That it allows you a way to selectively vasodilate only the areas that you want to vasodilate. Now, you can have some problems with it in terms of the downsides, the side effects. Patients with severe LV failure can be a problem, and but it has to be pretty significant. And if you have a patient who's on it for a prolonged period, you can run into a rebound effect when you discontinue it. There was at some point a concern about AKI with it, but that's probably not an issue because most of the data with that was high doses for long times. So really the downside most people worry about is dropping the blood pressure. That doesn't tend to happen.
And Sarah, you're taking the nitroglycerin from that bottle, you're putting it in a nebulizer treatment.
Yep.
This is exactly what you would do kind of with albuterol or Atrovent, same kind of container. What's your dose for this?
So that is not 100% clear because most people are not using this as first line. Like this isn't a first line thing. The dose that I like to try and give is something along the lines of like 2.5 to 5 milligrams over 15 to 30 minutes. In reality, what you're going to find is because it's such a large volume, if you do the math, you're like, wait, they're going to have to like nebulize and inhale a lot. So functionally, I just put a bunch in there and then just keep it going. Because it's going to take a while to actually get that in them. Now, milrinone is better because it's in a smaller volume. And so that can be a little bit easier to manage. So I actually tend to choose inhaled milrinone because they functionally, the mechanisms are different, but they do the same things. But yeah, you're thinking 2.5 to 5 over like 15 to 30 minutes.
And you have a video on the site talking about inhaled pulmonary vasodilators, specifically about nitroglycerin too, for pulmonary hypertension, like in a massive pulmonary embolism. People can check that out. I think it's very similar dosing actually that you're using in both of those. So people can check that out for a little more information, because this is clearly, you know, I think on the chat, people's heads are exploding thinking about putting nitroglycerin into a inhaled form, but you can see that, and that information is there. You've got some links to articles. So this isn't just something that you pulled out of nowhere and decided to try. There's some real data there. Now, here's the real crux of this, and you did allude to this. As an emergency physician, I have a patient in front of me. Should I be starting either nitric oxide or inhaled milrinone or nitroglycerin? Which patients should I be starting on? Or is this kind of more of, hey, you know, this is something we're researching, keep your eye out, but not really ready for prime time?
Yeah, I think it definitely that latter category. I mean, at the moment, you know, SCCM is saying, and I agree with this, that routine use, probably not a great idea. We just don't really understand this or have any data at all in this disease to say, let's just use it in everybody and see what happens. I don't think that's a good idea. At the moment, the only time people, or at least most people, are really using it is sort of a rescue therapy in super sick, mechanically ventilated COVID patients, where I'm like, I've tried everything I can think of and they're still hypoxic. So I've tried it as a rescue therapy, but in terms of routine use in the ED, not so much. Now, that being said, if the phase 3 study that's ongoing in the less sick patients turns out to have good results and is a good study and so forth and so on, maybe it one day could be something that we might consider doing in the ED, not just in the super sick intubated patients. So stay tuned. It's feasible. We're not there yet.
All right, Sarah, let's just wrap this up real quick. A couple of things that we hit on. Non-invasive ventilation is good. Go for it. Make sure you have proper PPE on. VTE management, if you're admitting them, put them on prophylactic dose. If they're going to the unit, they're critically ill, consider the full dose. Talk to your ICU, your intensivist about that. Make sure you have a good protocol in place. Pulmonary vasodilators, there's a theory behind this. There's physiology, really no data yet. We're not going to start doing this right now, but don't be surprised if you hear an intensivist say, hey, that guy's going to be down with you for a while. How about you throw some nitric oxide on him? Don't be surprised if you hear it. And as soon as actual data comes out, we will get Sarah back on to review that. And that's all we got for critical care updates. Let's kick it back over to Mel.
Thanks, Swami. That was a fantastic review. Before we go any further, Swami, I've had a number of people say, can you show your entire T-shirt? They want to see what's on there. They're seeing the top. Back up. Here it is.
All right. So it says, what did it say on the top? Not all heroes wear capes.
There you go.
Yeah.
Fantastic. Look, thanks for everybody involved. I'm going to hop down here and show you everybody in the chat here in a second. But for everybody out there doing this thing, looking after the patients, you know, we say it every month on the show. I don't want to overdo it, but this is your time. What you do really matters. You are saving lives in this terrible time. Hang on. I'm going down there. Wait. There it is, gallery view. To everybody that was involved and to all the people behind the scenes, thanks. We will do our next live next time we feel like there's enough stuff to talk to you about. All right? Be safe, be well. Talk to you guys soon. Out.